All right, so I couldn't have asked for a more serendipitous introduction to today's topic, um, and no relevant disclosures for this. And so we just saw a case like this, right? And the question becomes, how do you get to and address lesions in this area, whether they be in the ventricle or in the dorsal brainstem themselves? How do you expose it surgically? How do you incorporate neuroanatomy to safely remove it or at least maximize your resection? And you don't want to be this surgeon, right? You don't want to just walk in there and not have a plan. You want to have plan A, B, and C, and you want to mentally rehearse these more complex cases ahead of time. And so whether it's here or anywhere else, when you're designing an approach, there are a couple of things you need to take into account. One is, what do you need? Well, here we need access to the floor of the fourth ventricle, right? And which is the purple area that's highlighted. And we need safe entry zones into the brainstem, right? What we want and what we need are two different things. What we want is the shortest possible route. And sometimes the shortest route isn't the safest route. Okay, so we have to balance those. We want the widest possible angle of attack, or so-called surgical cone, right? So a lot of times when you look at articles that are comparing surgical approaches, they'll project these cones that they've devised based on the neuronavigation and a field of view, right? So if you have a narrow field of view, the problem is oftentimes you can see stuff you can't reach. And more importantly, you may have stuff hiding outside your field of view. And then, as we said, obviously you want to minimize disruption of parenchymal structures. And I always try to minimize or avoid the use of retractors if possible. So how are we going to get there? Well, this is nothing new, right? So Ghazi Yassergil in the 60s and 70s was the person who really became the proponent of, follow the vessels like highways and then get off of them and get out of the cisterns as close to your target as possible. So his modus operandi was to traverse the cisterns following a vessel that would take you to where you needed to go. And in this case, the vessel we need to follow is pica, right? So you open the cisterna magna, which is a cistern, and that exposes your first segment of pica, your pica origin to your tonsillomedullary turn. And then you open the CMF, the cerebellomedullary fissure, and that exposes your first turn. You open the tonsillo-uvular fissure, that exposes your ascending segment and your second turn that takes pica out laterally again over the lateral recess of the fourth ventricle. Then your tonsillomedullary fissure, which is going to take it out past foramen Vlúška. So, in general, posterior fossa surgery, we all know how to do this, typically done in a concord. You could also do it in a sitting or a semi-sitting position. And I'm going to leave that up to dealer's choice. I typically do everything concord. I find the setup struggle with sitting position for me just isn't worth it, especially with hemostatics and everything that we have now. I think that there was a time when technology wasn't as useful. And then you're going to extend your suboccipital to include typically a C1 and occasionally a C2 laminectomy. And when you would extend that is if this lesion has basically created an associated Chiari-type malformation and push the tonsils down low, because you need to be able to mobilize the tonsils in order to do this approach. Doug?
The risk of people being prone to vision loss, is that really a compressive phenomenon? Is that really a problem in kids or a problem in the machine? Is that something I can consider?
So we learn about it, we talk about it, we consider it. We operate with people in the prone position all the time. It's more commonly reported in spine literature than it is in cranial literature. And the two things that seem to be associated, one is compressive. So if they're prone on a face pillow or a horseshoe as opposed to pins, You can get an elevation in intraocular pressure if the eyes are not left free. The other thing that seems to make a difference is whether they're head down or head up. So if they're head up and there's less venous congestion in the head, that seems to be associated with a lower incidence of retinal blindness postoperatively. Ryder.
I think two others. One is the length of time of the surgery. I think it's a big factor. The other is the size of the patient. Large body happiness.
Common scoliosis surgery, bone surgeries, not having a head of the bed up so that venous
But to me, there's a bigger risk of the alternative, which is the sitting position.
And anybody you guys know, what's the big risk with that? Yeah, air embolism and subdural hematoma formation. I hate the sitting position. It's so uncomfortable. Everybody says the blood drains out really well, but as a resident, I did see a couple bad outcomes with sitting position.
Yeah.
There's no way to monitor for that, right?
For which?
Precordial Doppler.
For air embolism, precordial Dopplers, retinal occlusion.
You can do
Theoretically, you could do visual evokes, but they're very unreliable in an unconscious patient.
when you say time, are you saying like 12-hour
Duration, yeah.
4-hour operation?
Yeah.
Yeah.
8+ seems to be the cutoff where the risk goes up.
Dr.
Yeah,
One more question. When you do the C2 Lambie,
yeah.
have you done a pure laminectomy, or do you try to do a laminoplasty and restore that?
Yeah, if the lamina is not involved, if it's not a spinal tumor, I do a full laminoplasty. So I drill 2 troughs, take it off, plate it back, reattach the axial cervical musculature to the spinous process. And if you're going to do that, do yourself a favor when you take it off and it's out of the patient, drill a couple of holes through the top of the spinous process while it's not in the patient, and you can throw heavy suture. You can throw like an O or a 1 suture through that on a big CT needle and really reattach stuff. Because that's the major morbidity of doing a C2 laminectomy, is the detachment of the axial nuchal musculature, right?
But I don't think you have to take the C2 off for most.
No, it's just when there's an associated Chiari. So speaking of monitoring, these, especially when you're going into the brainstem itself, they should be heavily monitored, right? So routinely, they're all going to get SSEPs, MEPs, and bears. And things to keep in mind, especially if you're working with an anesthesia team that isn't used to doing this all the time. For SEPs, you want to be more heavily weighted towards an IV anesthetic, less heavily weighted towards an inhaled anesthetic. So typically, you want to keep it below 0.3 of MAC, as opposed to, if you're doing total inhaled and you're up at 1 MAC. MEPs, you want either no paralytics or short-acting paralytics at induction. You want to maintain your MAPS and your core temperature. So if your core temperature drops below 36.5, then you're going to lose MEPS. You're going to lose amplitude in your MEPs. And then you're going to do EMGs. So you can monitor 5 if you're up higher through masseter monitoring. 6, you can put electrodes in lateral rectus and do abducens monitoring. 7 is pretty common for both neurosurgical and otologic procedures. 9 is soft palate, so pair of electrodes above the tongue, behind the hard palate. 10 is your vocal cords, and you can either use a NIM monitoring tube, or not infrequently the tube doesn't work even after it goes in, and you can do direct electrodes through basically cricothyroid membrane and pick up EMG activity on the vocal cord muscles. Then I think that for me, one of the keys is always making sure they have trapezius or SCM monitored, so you can monitor the nerves around the jugular foramen, and then tongue electrodes. And you always, especially when you're down, whether you're subcortical in the supratentorial space or you're extraaxial and stimulating through ependema in the brainstem, you want to use a bipolar electrode. You want the narrowest possible field of stimulation. So either a bipolar ball tip or a cartouche type electrode as opposed to the regular PRAS probe, which is a wide field stimulation. Doug?
Things about this, the monitoring people here are really great, but I help anybody who's but set the patient up and then have them set up their monitoring. Because particularly when you do middle fossa, you're going to have to take all the electrode leads out and start over because they start before we even get to the pins. Problem. The other thing is with the PRAS probe, a lot of people don't realize that only the distal movement. So people hit the side of the probe and won't get stimulation going. Only the tip. The stimulation drops precipitously if there's moisture in the field. And so what I tend to do is I'll take a cottonoid or cotton ball and suction through it so you're not actually damaging the nerve. So very careful.
Yeah, and then I think one other pearl is make sure you have a near field ground. So if they put their grounding electrode in the shoulder and you're stimulating below 1 milliamp and you're looking for small EMG activities, you're probably not going to pick it up. So you can, the two things you can do are you can put your ground in the forehead or just put a ground on the field after the fact when you're hooking up your electrode so that you're actually closer. Typical suboccipital craniectomy or craniotomy, depending on how you want to do it, very typical Y-shaped opening. And then, this here is really your trajectory is coming in under the vermis as opposed to splitting the vermis. And we'll talk about that in a minute. And this is really the first thing you see, which is opening cisterna magna and the inner hemispheric fissure of the cerebellum. Okay, so before we get back to more detail about the trajectories, a little bit of fun with anatomy. So, Bill, good morning. So, Bill, what is number 1 on this image? Yeah, there's a specific portion of the cerebellar vermis that it is. Anybody want to help him? Close. 3 is the uvula. Okay, 1 is the pyramid. Okay, so that's really, you're working with the pyramid and the uvula. And if you were going transvermian, that's typically what you would split, is the pyramid and the uvula. And the key with the transvermian is to not divide any higher than the fastigium, which is the inflection point between the inferior half of the vermis and the superior half. That's when you start getting into trouble. All right, so Dr. Patel, Keel, number 2, which has been removed here on the left side in order to, that's the tonsil. Okay, and we talked about 3. So now we're getting to the critical structures. Dr. Bonsali, what's number 5? Not quite. So 4 is the inferior medullary velum, and 5 is, anybody? The telocoroidea of the fourth ventricle. And that's where this approach gets its name, telovelar. Trans-telocoroidal, trans-inferior. This is the inferior medullary velum. Dr. Sasanto mentioned earlier the superior medullary velum, which is above and lateral to the frenulum of the fourth ventricle, frenulum being the decussation of the superior cerebellar peduncle, and that forms the superolateral roof. Okay. The inferior medullary velum is what connects your flocculus to your nodule. Okay, but it's essentially, you have no discernible deficit if you divide that tissue. It's more of an anatomic structural connection as opposed to an anatomic functional connection. Okay, so basically we're going to come in, we're going to open up these fissures. We're not going to remove all the vessels like they have here, so we'll get to the vascular images in a moment. And we're going to divide across here as opposed to just coming and splitting right down the middle. All right, so here again, sans any vasculature, we've opened the telocoroidea on the left side. You can see where it is on the right side here. And this probe is under the lateral recess portion of the inferior medullary velum, coming out foramen of Luschka. So that's how you connect your fourth ventricle to foramen of Luschka. And if you remove that portion there, which you have here, now this is the view we get. So again, number 4 is going to be the uvula, right? Number 1, Dr. Bonsali, is the tela, right? What's number 3 here? Anyone? Bueller. Voodoo economics. That's cerebellar peduncle, right? So that's the peduncular mass. Okay, and we'll see that in a cut cross section in a moment. And then number 2. Anybody know what number 2 is? I gave you a little clue. We've now exposed the lateral recess of the fourth ventricle, and this is sitting over a colliculus in the lateral recess. Anybody? So that's your dorsal cochlear mass, okay, dorsal cochlear colliculus. And then just below it, so here's how you localize it. The first outcropping just above these tracts that are running from medial to lateral is your dorsal nucleus. So those tracts, anybody know those tracts that run from medial to lateral and basically divide the floor of the fourth into an upper and lower? So that's the stria medullaris of the fourth ventricle. And so then number 6, because, so now we're above your dorsal cochlear colliculus. That's your dentate colliculus. Okay. And then number 5 is the supralateral recess portion of the medullary velum. All right. So switch views here for just a moment. Okay, so here it is with vessels in place, or at least some of them. So you can see your cranial loop of pica here. You can kind of see pica splayed open as the hemisphere and the tonsil have been retracted laterally, and you start to get an idea of the vascular relationships here. And so typically what's going to happen is that in order to expose the tela and the medial portion of the velum, you're going to have to retract pica laterally. Okay, but if you want to work for a lesion out in the lateral recess towards Luschka, you're actually going to have to retract that loop caudally and work above it to actually expose the recess, because when you retract it laterally, pica is covering that area. Okay. And we'll take a slightly closer look here at some of the vessels. And so what is shown here that wasn't previously present are the choroidal arteries that come off pica. Those can and must necessarily be divided in order to do this approach. And then there are a couple of veins that are important here. So the critical veins within the surgical exposure, what you don't see here is there's going to be a complex of veins sitting over this area. So there's a vein of the cerebellar medullary fissure, which is a confluence of a couple of structures. There's the vein here of the inferior medullary velum running transversely, the choroidal vein, okay, and then all of that drains into the supratonsillar vein, which forms a loop that kind of parallels that loop of pica. All that's going to get retracted laterally and superiorly. You're going to be left looking at these veins. And most of the time, if you don't need to be in the supralateral recess, you're going to stay below the vein of the inferior medullary fissure. And you can divide it if you need to, but it's a good landmark as the transition from the tela to the medullary velum. Okay, because tela, by definition, is below that vein. So if you divide up to that vein, this is what remains obscured, is this access out here into the supralateral recess of the fourth ventricle, which is a rare place to need to get to. But if you have a large lesion like Dr. Cobbs's case, you're probably going to want to open bilaterally and really just fillet open and unfold almost like one of those little origami things that just unfolds on itself to expose this area. And then this is a much steeper view because now we're oriented along the axis of the aqueduct looking straight up. So everything looks contracted and foreshortened because of perspective from this angle. Here again is another demonstration of the difference between dividing up to the vein of the medullary fissure as opposed to across the medullary fissure. And what you really expose is the bulk of the mass of the peduncles out here. Okay, so we've safely gotten to the floor of the fourth ventricle, but now we need to know where we can actually safely enter the brainstem and where we need to be concerned about possible trauma. So this is, the view that you get. Once you get to the floor, it's avascular. Here's a slightly better view with labels. Here's the stria medullaris that we talked about. You can see that running from the median sulcus, which is number 4, out laterally over the cerebral peduncular mass, out laterally. And so with that orientation in mind, top, bottom, midline, lateral, Dr. Bonsali, here's a cross-section in the coronal plane of the peduncular mass. What are number 1, number 2, and number 3? You got a 33.3% chance on this. So it's all cerebellar. It's all going to end in something cerebellar peduncle. Okay. Correct. So the largest peduncle is the middle cerebellar peduncle. That's number 1 here. And you can actually see, almost looks like a little trident or Mercedes symbol that divides them. Number 3 is superior. Number 2 is inferior. All right. Well, since you're on a roll, 6, 7, and 8. Yeah, so 8 is obex, and 7 is you said hypoglossal trigone, not triangle. Okay, so just superior and medial to that is going to be your vagal triagone, right? And then you mentioned the infraclavicular triangle. Well, your colliculus is really up here, okay? And then 4 is your median sulcus. So here's another both diagrammatic and anatomic view of this area, right? And so really the key structures that you need to use to orient yourself are the stria medullaris, which are really the only structures that run transversely in this area. Everything else is running up and down. Your facial colliculus. And with that, you can kind of figure out the rest. Keeping in mind that there's a third trigone underneath the hypoglossal trigone that we don't call it trigone, we call it the area postrema. And it tends to be slightly pigmented because it's serotoninergic. Okay, lateral to the trigones, which you don't necessarily see on this section, but you can see on others, is another pigmented area, which is the area ceruleus, the locus ceruleus of the brainstem. So another area where neurotransmitters are produced. Okay, so now we start to peel back the layers, now that we have that overview. And these are really the dorsal tracts that we need to take into account when we're picking an area for getting into the ventricle or getting into the floor of the fourth. So on the left side here, ependymal floor. On the right side, we've peeled back ependema, and one of, I think this was Yammerglue and Roten's lab, has accentuated the structures. Still don't know how they do this. So, Dr. Patel, the yellow highlighted structure. Okay. Dr. Bansali, yellow highlighted structure corresponds to this round outcropping in the epinema on the left side. Say that out louder. So that's your abducens nucleus, right? Remember, the facial colliculus is not the facial nucleus. It's the abducens nucleus with the facial nerve, shown here, coursing around it, right? So the facial nucleus is out here in the infralateral recess. The fibers course medially, then there's an ascending, and then another laterally traversing segment to come out and exit the brainstem. And the bulk of these two is what forms your facial colliculus. So when you're stimulating on the floor of the fourth ventricle to figure out where these things are, and sometimes you don't see the colliculus in the floor. Sometimes it's perfectly flat, especially if they have had something that's obstructed the obex and obstructed Luschka, and there's fourth ventricular hydrocephalus. You may not see any of these features. So you need to be set up, and you want to be able to stim both abducens and facial nerve and pick up both of them. All right. So with that in mind, Bill? That is the medial longitudinal fasciculus, right? Okay. And how about out here laterally? So this is just at the superior margin of the lateral recess of the fourth. It looks like two structures here, but it's really one motor nucleus. What motor nucleus is this? That's 5, exactly. So 7's going to be down here, 5 is here, 6 is here. All right. And this is important because this becomes a limiting structure in terms of our supracollicular entry point. Associated with that motor nucleus is this tract. Anyone? Bueller? Trigeminal mesencephalic tract. Okay, because this is heading up to the mesencephalon. And then this is also an ascending, it's actually an ascending and descending tract. So it goes both ways. It's not associated with the trigeminal nucleus. Anyone? It's associated with both the red nucleus and the the nucleus solitarius. So this is the central tegmental tract, okay, which the ascending portion we call the tractus nucleus solitarius, and that's carrying taste information from the nucleus solitarius up to VPM thalamus. And then the descending portion is the rubro-olivary tract, carries information from the red nucleus down to the inferior olive. So an overview of the safe entry zones. You have a couple of different ones, but there are really two workhorses. Theoretically, you could go midline and split it perfectly, almost like entering the dorsal columns of the spinal cord. Wouldn't recommend it because really any retraction on the MLF is going to cause a gaze palsy. So oftentimes this is useful only for lesions that erupt up to and kind of through the floor of the fourth. So a larger cavernoma, a larger tumor. But if you have a small intraparenchymal lesion, I would not recommend choosing this. And the same is true for this superior fovea safe entry zone, which is really limited. You're lateral to the facial colliculus and inframedial to the trigeminal motor nucleus. It's not a very wide trajectory. So really, your keys here are this suprafacial or supracollicular entry and infracollicular entry. You don't have a lot of room to work here. So we'll take a closer look at those. So here is your supracollicular safe entry zone. The medial border of it is your MLF. Your lateral border is basically the sulcus limitans, which is going to be the feature along the floor of the fourth that denotes the medial border of the trigeminal mesencephalic tract. Okay. You can go down to where the facial nerve is. So this is where stimulation is important. You want to pick up where you start stimulating along the facial nerve. Okay, and you can take that all the way up to the frenulum veli, which is the decussation of the superior cerebellar peduncle, and basically the top of the ventricle where you start to get into the aqueductal outflow tract. And here's a cross section here. I'm happy to share these slides with you if you want to review it in a little bit more detail later. Here's that superior fovea safe entry zone, and again, we are bounded medially by the collicular mass, facial colliculus. Superiorly, really the motor nucleus of 5 is what's limiting us. Here's sulcus limitans running here. And then inferiorly, we are bordered by what is going to be facial nucleus out here, not shown on this one. Working below the colliculus, we can basically come down to the beginning of the vagal trigone. Okay, and the vagal trigone occupies a large amount of space here, so it's a very narrow entry point. Telovelar versus transvermian. This is an anatomic study, again out of Roten's lab. Tenrovia was one of his fellows at one point, comparing the trajectory of approach. Basically, there's no difference in what you can reach when you go transvermian versus telochoroidea in terms of craniocaudal. When you go telovelar, you can reach further laterally than you can with a transvermian approach. And when you go transvermian, that's actually the green shown here because you're limited in how far up you can split the vermis. So when you go telovelar and you're slightly off midline and kind of going around the uvula and the pyramid, you actually have a more shallow angle of attack than you do splitting the vermis and trying to sneak in through an enlarged obex. And that's also shown here. They compared on neuronavigation how high, how low, how far lateral they could get. And I think we'll stop there for today.